So I want to take a minute and talk about the therapeutic relationship and the Therapeutic Alliance. In all of our clinical models, a connecting relationship with your client is critically important, and you all know that. Within the context of social work in general, relationships are hugely important. In fact, when we look at social justice issues, when we look at issues of oppression, at the core of this is relationships between people, relationships between organizations, relationships between government and society. And the effectiveness and the health of these relationships are critical to the well-being of individuals and society as a whole. So in many ways, the therapeutic relationship isn't just about a technique to improve outcome, but it is actually the outcome itself, that we are hoping for individuals to have healthier, more functional, more balanced, and less oppressive relationships, both at a micro and at a macro level. So in some ways, sort of pulling out this issue of relationship from this broader context, this broader sort of social work understanding, and looking at it within the context of individual therapy almost seems like, yeah, of course, it's important. But I think when we look at different models and when we look at how different people sort of formulate what the relationship is about in a clinical situation, in an individual one-on-one situation, there's a number of questions that we have to consider. The first question is, what is the healing aspect of the relationship? How are we using the relationship in terms of healing? And secondly, what is the nature of the relationship that the clinician is going to carry on with the client? So cognitive behavioral therapy has a particular perspective on this, and there's a wide variety of perspective depending on which therapeutic model that you're following. So in terms of how does the relationship affect the healing process, some models put a huge amount of emphasis on this. In some ways of thinking, it's the relationship between the client and the therapist that creates healing, and that the therapist and the client are in a dance where they're working out the client's relationships that they have in the broader society. So if they have difficulty in relating to people in authority, for example, the client is working that out with the therapist, who becomes sort of a representative as an authority figure. And so the ideas of transference and countertransference are particularly important in those models. CBT takes a different perspective. It doesn't look at the relationship so strongly in terms of the healing process. It sees the relationship as something that's necessary for the clinical relationship, but it's not sufficient to make therapy effective. So you have to have it, and if you don't have it, therapy will be difficult, but it isn't the thing that heals the person. So there's sort of a less sort of emphasis on that. The emphasis in CBT isn't on the relationship as much as it is on what is the client going to do after the session. This sort of idea that the magic doesn't happen in the session, the magic happens outside of the session. And so we as CBT therapists don't view ourselves as so powerful that we can have this amazing interaction with our clients that's going to phenomenally change their life, and that 1 hour a week is somehow going to influence every other hour of the week. So we're really looking kind of at the client becoming their own therapist and not needing us so much to be the one that heals them. The second piece of the therapeutic relationship is about what kind of relationship does the therapist have with the client. And so in this aspect, we see our relationship as a supportive relationship, as an encouraging relationship. But again, we see treatment as being time limited, and that the relationship will end. and hopefully the client will move on to other relationships that are more natural and more normal in their life. Some models have a tendency to put so much emphasis on the relationship that the client is at risk of becoming dependent on the therapist. And so in CBT, we're not looking for that at all. We're looking for the client to become their own therapist and to be able to manage without the need of the therapist. We want to work on relapse prevention. Our goal is to keep them from coming back, not to be so needy of this highly supportive relationship that they can't function without us. So one of the things that I like in Judith Beck's book is this phrase that she says that you strive to be a good person in the room. And I really like that because it just sort of is very simple and very basic. But you want to be a nice person for that client. Now, of course, we want to build the relationship beyond just kind of a nice person. And in CBT, we put a lot of the emphasis on empathetic listening, those quality listening skills that are part of your basic counseling repertoire. And very core to that is the ability to repeat back to the client what you hear the client saying. So if the client is describing something to you that is of concern for them, that is painful for them, they want to know that you're hearing them. And the way they know that you're hearing them is that you repeat that back to them. And so some of these technical skills of parroting, where you repeat back what the client says almost verbatim, or paraphrasing, where you grab at the essence of what the client is saying and repeat that back to them, is critically important because it allows the client to feel like they're being heard. Now, within CBT, and I think all models, we also add in the idea of being able to do good summaries. Being able to hear the collection of information that the client is giving you and being able to summarize it. What this does, in addition to communicating to the client that you hear them and that you understand them, it also allows them to hear themselves. Because what you're summarizing for them is exactly what they've already told you. So often clients come to us with a lot of chaos in their own minds. Everything is confusing for them. They don't know how to respond. They don't know where they're going with what's happening. And the simple act of you summarizing what they're saying helps them organize their own thoughts and makes things clearer to them. So when we move on to talking more about Socratic questioning further in the course, this idea of clients being able to hear what they're saying, reflect on what they're saying, and make some judgments about what they're saying becomes an important skill. We also want to keep things on the positive. We want to emphasize client strengths. We don't want our interviews to be so problem-focused that clients come away more depressed than when they started. Now, a lot of these concepts around active listening and validation can get quite technical. I think a real simple way of looking at it, though, is just that you're really interested in client stories. I think if you have a genuine interest in what's happened to clients and a genuine interest in understanding why they do what they do and what's going on in their mind when they do things, that will come across to the client as genuine and that you're really listening and you're really caring. I once said this to a class, and a student came up to me afterwards and said, "Oh, I was really glad that you said that." And I said, "Oh, why?" And they said, "Well, I thought I was just nosy." And I like that because I think part of the characteristics of individuals that come to our profession that are interested in this work is we have sort of a natural curiosity about people, about what they're doing and why they're doing it. Now, when we consider relationships in that therapeutic alliance, I think there's a couple of things that we need to keep in mind about it. Firstly, there's some good research that suggests that we're actually not very good at evaluating what our relationship with a client is like. It seems that most clinicians overestimate the quality of the relationship that they have with their clients. So this is kind of disturbing, but the implication of this is that we need to be actively seeking feedback from our clients about how it's going between us and them. Are we on track? Are we doing the things that are important to them? Have I said anything that offends you? Is there anything that happened today that that didn't feel right for you? And so those kinds of questions where we actively seek feedback seem to be important. Another piece that's, I think, interesting about the relationship that comes from the literature on cognitive behavior therapy is that it's not just that a positive relationship leads to better outcome, but the reverse is also true. That if you are having good results with your client, if the client experiences you as someone who helps them and that their problems are getting solved and their distress is being alleviated, they will report a better relationship with you. And so it's a bit of a cyclical kind of thing, that the relationship leads to better outcome, but better outcome also leads to an improved relationship. And I think kind of the practical learning from this is that sometimes we get caught up in just focusing on the relationship, and we lose sight of we need to do things that help clients. And if we can do practical things that lead to help for clients, then that improves the relationship. It's not just always about focusing on the relationship. This brings us to the question of what are the characteristics of a positive therapeutic alliance with a client. Scott Miller uses the analogy of a three-legged stool, that there's three legs to hold up the relationship along with the seat. The three legs are made of, firstly, the therapist's behaviors. Empathetic listening, collaborative work, seeking feedback, working together with the client. That's one leg of the stool. The other leg of the stool is that the client and the therapist have agreement on what the problem is. So it's not a situation where the therapist has defined one problem and the client is trying to solve a different problem. So there's agreement on what the problem is. The third leg of the stool is there's agreement between the therapist and the client on how to solve the problem, so that the direction you're going is understood to be something that's helpful to the client, and both from the perspective of the clinician and the client. The seat on the stool is choice. Does the client perceive themselves as having choices that they can make in terms of what's going to be done to be helpful? So from a CBT lens, this means we work collaboratively with clients. We're continually seeking their participation and input into the planning and the direction of the treatment. So in terms of CBT, how this translates into some of the behaviors of the therapist is that we always want to be sharing our conceptualization of what's going on for the client and the treatment plan. We always want to be having a dialogue with our clients, and their client should always have a sense that our conceptualization and the treatment plan ring true with them. We want to be collaborative in all of our decision making, so we're not pushing one particular road without discussing that with the client, without getting the client's input. And we're encouraging the client to come up with their own ideas and their own suggestions. We're always trying to elicit their participation. We're always wanting to seek their feedback. Does this fit for you? Is this working for you? Should we go a different direction? Have I done something that hasn't gone well with you? Should we be doing things differently? So you're always wanting to be pursuing that feedback. And at the bottom of all of this, your goal is to alleviate the client's distress. So that is, from a CBT perspective, is one of our key pieces, key directions that we're going with clients. And that really helps support the therapeutic relationship. Anyways, those are some thoughts on the therapeutic relationship, and I hope that is of use to you, and will give you some thoughts for reflection.